chest. And sometimes it so happens that there is a voluntary spasm. So how do you relieve that voluntary spasm? The relief of the voluntary spasm is तिला खाली करण्यास एकदा तुझ्या मांडीवर डोकं ठेव आणि तिला So what you do is that you take the patient to the edge of the table, don't leave, and then look for next difference. Have you understood? So the best way of relieving the voluntary neck spasm is that you obviously you catch hold of the patient, you take the patient to the edge of the table, and so that there is a free fall of the head. The moment there is a free fall of the head, automatic neck flexion, which is voluntary, will go, and therefore you will have to it will be a lot more easy. Maybe can you all see? बच्चे आप दोनों को नहीं दिख रहा है ना, तो आगे आ जाओ, यहाँ से आ जाओ, यहाँ से दिख रहा है एक विंडो है. Can I do one thing? I'll sit down so that मेरे पीछे से और 2-3 लोग देख सकते हो. Now पीछे वाले आ जाओ पीछे. Can you all see? Please accept. So this is as far as neck stiffness is concerned. So this is hair neck sign. Okay. Now you have a Brudzinski's leg sign and you have a Brudzinski's neck sign. So what is the basic principle of any Brudzinski's sign is that whenever you have a spine and you have an inflamed meninges, the moment you stretch the meninges, there will be rubbing of the meninges on each other, and then what will happen? There will be pain, and then you will go into flexion. So your body will not allow extension of the spine, and an overextension would be supposing the patient is like this, all that you need to do is keep an angle here and you extend this. So the moment you extend this, what has happened is that ideally it should be straight, extend. If you extend, the spine goes into extension from behind, and what will happen that you will automatically go into flexion. The patient goes into flexion. So that is the leg side. Similar in the neck side, all that you need to do is that the patient is lying down straight. You are not supposed to bend the limbs, and you ask the patient to touch this, or you do it like neck stiffness checking. And the moment you do that, what will happen? Again, you are extending the spine, so your legs will be drawn towards the abdomen. So that is called as a Brudzinski's neck sign. Have you understood? So neck sign and leg sign. Okay, great. And the third thing is called as neck sign. Okay, and then you have this side. It's like you just ask the patient to extend onto the shin and extend. He will or she will not allow this. Okay, so these are the 3 signs. So neck stiffness, Kernig's and Brudzinski's. Have you all understood this? Okay, so this is something which they ask even in postgraduate examinations to demonstrate. In fact, this MD exam, they were unhappy because some of my residents were unable to demonstrate these 3 signs. So they will pakka ask you. I'll tell you something, I will teach you CNS to such an extent that I want all of you to attempt a CNS case. We generally pass any candidate who even attempts a CNS case. It's much more easy to pass a CNS case, believe me, because it's like mathematics. No? It's very, very easy. Okay. Have you all understood? So this is as far as whenever you see any CNS case, it's in the general examination, besides your pallor, edema, icterus, vagara, you are going to see 3 important findings, and one important finding is raised ICT. Second important finding is the meningeal signs, and the third important finding along with massive ones. Now in this patient, he has a craniotomy done. So I will not do the massive ones. What is a massive one sign? Massive one sign is called as crackpot resonance. You know that the skull is a very fixed base. So the moment you have pressure building inside, it's like a coconut. The moment you have a pressure building inside it, you start separating from the sutures. So it's like a cracked coconut. So when you know you have a coconut, your pot to crack karte ho. So how do you demonstrate a massive one sign? Can I demonstrate it on you, Vita? Is that okay? Okay. I can't do it on this babies because it will hurt. So you have to keep one ear on one parietal prominence or frontal prominence and tap on the other. Okay. And if you see a crackpot resonance, yeah, you can do it on each other later. Yeah. So this is how you take care or take her and you just tap on the other side. Did I hurt you?
No.
Okay. So you just tap. So or what you can do is that if you don't want to keep your ear, you can keep your stethoscope on one side. Okay, diaphragm, and then tap on the other side, and you will hear a crackpot of resonance. So this is a normal sound which you get, and उसमें ऐसे आवाज आता है ना, as if a crack has been made in a pot. So that is called as Massivans positive, which is a sign of raised acidity. Okay. So, but the beauty is that you cannot see Massivans when the AF is open. और देर इज ऑलरेडी अभी क्रेनियोटॉमी मतलब क्या पूरा बोन निकाला है, तो इसमें हम लोग नहीं दे सकते, तो बिकॉज ऑलरेडी ओपन है ना. Massivans is to be seen only when the sutures have closed, the AF has closed, and now pathologically it is trying to open. अब इसमें तो देखने का सवाल ही पैदा नहीं होता, बिकॉज इसमें क्या है, वो ऑलरेडी ओपन द cranium for a craniotomy. Okay, have you all understood? And the third thing is neurocutaneous markers. There are 6 neurocutaneous markers which you have to see. One is the neurofibromas, so those lesions, yeah. Then cafe au lait spots. Cafe au lait spots, significant cafe au lait spots is one spot of more than 5 centimeters in pre-adolescence, and or rather not and or more than 5 to 6 spots of 0.5 centimeters. Okay. Some books mention 0.5, some books mention 1 centimeter. I think Nelson नए में 0.5 है. Okay. So I think घड़ी में 1 centimeter दिया है, but I think go by Nelson. Nelson mentions 0.5 centimeters. Okay. So that's cafe au lait spots. Okay. Third, न्यूरोफाइब्रोमा का पेशेंट है कि डिस्चार्ज हुआ बच्चे?
वो उसी दिन they were asking.
वो क्लासिकल था अपने पास. हमारे पास एक न्यूरोफाइब्रोमास था एंड इट वाज अ बुक थे, उसके पिक्चर निकाला है.
पिक्चर्स लिए मैम रेजिडेंट उसके सौरभ के फोन में मैं बोल,
तो उसको बोलो ना अभी लाने के लिए, तो फोन पे भेज देगा पिक्चर्स, तो मैं इधर ही दिखा दूंगी ना, तो अपने इस पे ही दिखा दूंगी. ओके. देन थर्ड इज axillary freckling. You ask the patient to lift the arm or you extend the arm, and in the axilla you will see freckling, जैसे चेहरे पे freckles होते हैं ना वैसे. So that is called as axillary freckling. Fourth is ash leaf macule. So ash leaf macule मतलब एक कनाडा का झंडा अगर व्हाइट कलर का बॉडी पे कहीं पे व्हाइट स्पॉट, it is called as an ash leaf macule, which is a significant finding in tuberous sclerosis. Then you sometimes have these port wine stains. Okay. Then you also have something called as adenoma sebaceum. It's basically sebaceous. Actually that patient also had it. उसका फोटो निकाला है देख. Adenoma sebaceum. You know, it's as if you have a lot of these puncture marks on the face. It's as if you आपने ऑरेंज को देखा है ना, जैसे आप ब्रेस्ट सीए में प्योरी ऑरेंज, वो अगर चेहरे पे दिखा तो उसको बोलते हैं एडेनोमा सेबेशियम. ओके. So that is another neurocutaneous markers, and neurocutaneous markers are one which are important because they have intracranial extensions and therefore are very relevant in a CNS case. So अगर वो सारा पिक्चर भेज देता है तो I'll show it to you on the board only when I do the discussion. Okay. So have you understood general examination में? This is called as system specific general examination. See what is system specific general examination? मतलब general examination में आप vitals तो करने ही वाले हो, anthropometry तो लेने ही वाले हो, head to toe tickle करने ही वाले हो, head to toe examination करने वाले हो, but इस head to toe के अलावा ये 3 चीजें हर CNS केस में बोलनी है. First is raised ICT, second is meningitis, third is neurocutaneous markers, and fourth is skull and spine. Skull and spine care हम लोग सभी cases में बोलते हैं, but in a CNS case, the spine is very important, especially a tuft of hair or a sinus in the back, which tells you a neural tube defect underlying. So it is either spina bifida occulta, or it can be a tethered cord syndrome, or it can be just a myocele or a meningitis. It depends on what level the arrest has happened. So what you need to do is that बच्चे मेरा पालका जो होता है No, Jopadi Godaba, obviously this is the time to sleep, no? You. No?
1 o'clock.
1 o'clock, very good. तो माझ्या सकाळचे बेवडा काय करतो तू रात्री 1 पर्यंत? See what you does? Okay. थोडा खाली करते बघते. This speaks such good English. तू का नाही झाली का डॉक्टर सोनिया? काय नाही झालं?
तशी करू नको बाय.
केली तरी खेळायची एवढं काय शी काढायला किती वेळ कॅन यू ऑल सी जस्ट सेपरेट सी कॅन यू सी अ डिम्पल हियर दिस इज द डिम्पल which usually you have to the significance of the dimple is if it is placed 1.5 to 2 centimeters above the end of the spine, so that is a very significant finding which is coming up in spina bifida occurta which is called as a डिम्पल आपको दिखा वो अगर और डीप होता है वहाँ पे फिस्टुला होता है वो सिग्निफिकेंट ओके बर आई एम सॉरी तुला कळलं का तू एकदम गदरचा सनी देओल झालाय गुड्डे भाऊ ओके सो ओके so this is as far as the general examination is concerned. All of you have understood. तो CNS के general examination में ये सब कुछ पूछना है. Okay. Now we start with the neurological examination. And a neurological examination starts with your higher functions. And the higher functions may always remember the acronym COMEDIS. COMEDIS. DYS ने DIS. So consciousness, orientation, memory, emotions, delusion, delirium, eyes, intelligence, SS, speech. Comedies. Okay. The mean में भी उठाया ना so it's like this. Okay, 1, 2, 3, 4, 5, 6, 7. And this is not after 20 years of teaching. Right from second MBBS, I've learned it. So in front of the mirror, when you do a self-talk, ये सब अभी 3 महीने बच्चे हैं ना ये रट्टा मारना बिकॉज इस ऑर्डर में बोलोगे ना एग्जामिनर आपको पूछेगा ही नहीं सो कॉन्शियसनेस इज ही इज कॉन्शियस इज ही ओरिएंटेड टू टाइम प्लेस एंड पर्सन ही इज then memory he has a good memory because the moment somebody comes in a white coat he starts crying because he gets scared of the especially ward में sister जब आती है ना तो रोना धोना शुरू because they know that they're going to get a shock so that is it's an idea that his memory is short term memory seems to be good okay so then delirium hallucinations cannot be judged in a small child then I is intelligence. He's an intelligent child. I've spoken to. His intelligence seems okay. He's very intelligent. And S is speech. And speech is something which is not in sync with his other general conditions. बोलत नाही का बेटा?
बोलते थोडं
थोडं बोलते.
तशी आत्ताच्या काळात ती कशी बोलते फोनवर बोलले ना नाव घेते ना अक्षय म्हणते त्याच्या पप्पाचं नाव अक्षय म्हणते अक्षय बोलते अशी नाही बोलणार फोनवर शिवाय समडे
बट देन शी वॉज टॉकिंग प्रायर टू दिस टॉकिंग ती आधी बोलत होती पण आता बोललं तर उत्तर व्यवस्थित मिळतं म्हणजे आता तू काय करते तर मम्मम दे म्हणलं की पाणी दे म्हणलं की म्हणते पाणी दे मागते
ती बोट करते पाणी
पण बोलू नाही ओके so there is a word output which has got down after the words and it is obvious it's a left sided
जे मित्र खेळायला नेते ना ते ऑब्झर्व करते मग बॉल कोण दिसलं ना हाडकं ना बॉल दिसला तर ये म्हणणार घे म्हणणार
okay so that means what is she saying understanding is good comprehension is good memory is good intelligence is good but word output has okay so this is a very important key marker which you have to highlight in this because here your Broca's area is situated and this is a motor component of speech which is probably a little disturbed because she's been operated there simple reason okay so this is as far as speech is concerned have you all understood comedies okay now you come to the cranial nerves okay now quickly how to assess the cranial nerves if you look at the general condition of the face there is no facial asymmetry so there is no drooping of the eyelids or anything so that means technically the 7th and the 3rd nerve seems okay there is no obvious squinting now which squint is very important in this child is 2 squints one is your convergent squint, because you know that the longest intracranial course is of the sixth cranial nerve, and you know it runs through the base of the brain. So the moment you have a pressure building up on the sixth cranial nerve, what will happen? The sixth cranial nerve goes into convergence. So you will have a convergent squint coming up. So that patient does not have a convergent squint. And another squint which is very important is the fourth cranial nerve, that is a that is a trochlear nerve, where you have a superior oblique palsy. So superior oblique palsy is a copying muscle. Superior oblique is a copying muscle. मतलब जो muscle अगर मैं right को देख रही हूँ तो मेरा left जो आँख है, so it's going to come down into this angle, नीचे पीछे. So that is the action of superior oblique. That's a copying muscle. If you want to copy from someone, how do you put your eyes? So when you're copying, your right superior oblique, on the right side, is going to guard the left. So superior oblique brings the eyelid down, the eyeball down, and the inferior oblique pulls it up. Now if you have a fourth nerve, we say SO4, superior oblique fourth cranial nerve. If you have a trochlear which is damaged, your eye cannot be pulled down. So where will the eye go? In the opposite direction. So on seeing, if your eye has gone tena up, you know it is a left superior oblique injury. Have you all understood? Why is the trochlear nerve important? Is because the trochlear nerve is the only cranial nerve which comes out from the posterior part of the brainstem. It doesn't come out from the anterior part of the brainstem. So the moment you have a pressure building up between the brain and the cranium, which gets blocked is the trochlea. And therefore these are two essentially important cranial nerves when you're talking about raised eyes. Have you all understood this? Okay. So which two cranial nerves? Sixth and fourth. And we generally don't talk about the fourth in alone. We call it 3, 4, 6. Okay. But if you can see a squint, you have to talk about whether it is a convergent squint or it is not. And in ophthalm, you must have heard about paralytic squint and non-paralytic squint, or concomitant squint and non-concomitant squint. ये भूल गए भाविका, चेहरा ऐसे किया उसने. हे भगवान, short term memory losses, doesn't it? See, paralytic squint is because of the damage to the nerve, and a non-paralytic squint is because of damage to the pathway. Always remember, paralytic squint is because of the damage to either the nerve nucleus or its pathway. And if you have an ocular pathway, उसके पहले न्यूक्लियस से पहले अगर कुछ प्रॉब्लम है, जैसे लेंस में प्रॉब्लम है, रेटिना में प्रॉब्लम है, जो स्क्विंट आएगा इसको नॉन पैरालिटिक है. Seriously, have you understood this? Okay. So paralytic squint क्या होता है कि आपको accommodation का सवाल ही पैदा नहीं होता है, because of nerve paralyzed ही. मतलब आप कौन सी भी दिशा में देखो वो एक्शन काम ही नहीं करेंगे. Whereas non-concomitant squint में आप एक्सेसिव प्रेशर लगाओगे या उसकी ग्रेडिंग प्रेशर लगाओगे तो वो काम करेगा, because there is no paralysis of muscle. It is just a deviation in the angulation of the light rays. Have you all understood? So that is the basic principle of paralytic and non-concomitant. Always remember, for neurology, for ophthalmology, concomitant and non-concomitant is very important. For us in neurology, we are generally worried about paralytic squints because they are the ones who have an intracranial problem. And we understand a brainstem problem, for example. So that's one thing. Second thing, in the eyes, always look for ptosis or partial ptosis. So if you have a ptosis, you have a third nerve palsy. Because it is the LPS, levator palpebris superioris. Okay. Then there are two aspects to it. One is a ptosis and the one is the closing or tightly of the eyes. They're two different issues. One ptosis is because of the third nerve, and closing the eyes tightly is the seventh nerve, facial nerve. So if you have an element facial, your eyes will be like this, like this. It will not close properly. But if you have a third nerve palsy, a Horner's syndrome, for example, you will have the eyes drooping of the eyelids. Okay? So that's the difference, okay? So though it's all to do with LPS, it is basically the function which is important, okay? Now, in the seventh nerve, what you need to see is that you are going to look at facial asymmetry. Remember, the seventh nerve has everything to do with this part of the face and this part of the face. So if you have, you know that the face, if you look at the homunculus, the upper part of the face has bilateral representation. And therefore, there is no which ways that only a human palsy will cause a problem, because then the other side will take over, right? Therefore, in a UMN palsy, only the lower side of the face, ipsilateral lower side of the face will be affected. Okay, so if you have a left UMN facial, you have this part which is being affected. But if you have a left LMN facial, the entire half of the space is affected, is because it supplies the entire face. So you have loss of wrinkling on the forehead, you have a loss of nasolabial fold over here, you have an angular out like this, you know, this a drooping angle of the mouth, and therefore you have saliva drooling out of the mouth. So if you ask them to talk or you ask them to blow a balloon, air escapes from this end. If you ask them to talk, this facial becomes overactive. It pulls the angle on the other side. So the right side angle is pulled up, whereas the left side remains there. Okay, so have you all understood? So that just tells you. So in a left-sided facial palsy, if it is UMN, only the lower part of the face is going to be affected. The nasal labial fold is going to be lost. The angle of the mouth is going to be drooping on that side. There will be dribbling of saliva from that side, and you cannot blow from that side. You will have air escaping from that side. But if you have a left element facial, the entire face along with this, so all these signs will be there only. So there will be drooping of the angles, dribbling of saliva, nasolabial fold which is being lost. But along with that, there will be two other things. That inability to close the eye completely, which happens in Hansen's disease sometimes. So you have corneal ulcerations. And second thing is loss of wrinkling of the eyes. So all that you need to do is that इन अ स्मॉल बेबी दे आर नॉट कोऑपरेटिव. जैसे अडल्ट में आप बोल सकते हो कि ऐसे ऊपर देखो, बच्चे जब रोते हैं ना तो फेस देखो, जब रोते हैं तो यहाँ पे कुछ भी नहीं दिखाई दे रहे. यूजुअली व्हेन दे क्राई or they frown, they have these wrinkles there. When they are crying, if this part has no wrinkling at all, you know that you are. And do you have a facial sitting there? No, you don't have that. Okay. Okay. Sometimes, now this is a very crooked question I sometimes ask to students who are good, is that how do you know that is this a congenital facial palsy or is it an acquired facial palsy? Always remember, congenital facial palsy is also a phenomenon which is due to the non-development of the facial nerve nucleus. But the beauty about this disease is that this facial palsy becomes more overtly evident on crying and emotional disturbances. वैसे दिखेगा नहीं, but जब वो रोता है तो वो facial palsy automatically brought about होती है. In the other way around, if it is an acquired one, emotions पे शायद facial आपको नहीं दिखेगी, but बोलने पे आपको facial asymmetry दिखेगी. Have you understood? If you remember, inacquired, in congenital emotions पे ज़्यादा आता है. ये याद रहा ठीक है, but my postgraduate से all I heard, this is something which I always ask in the exams. Please remember this, okay? So this is about 7th. Why did I start with the 7th and the 3, 4, 6? Because these are the most evident in pediatrics. आप इनको टेस्ट कर सकते हो, आपको ये दिखता है. आपको फर्स्ट नर्व तो नहीं टेस्ट कर सकते, बिकॉज बच्चा क्या बोलेगा. फर्स्ट नर्व टेस्ट करने में क्या करना है, इसकी आंखें बंद करनी है, एक नॉस्ट्रल बंद करना है, एंड पेपरमिंट चॉकलेट आपको टेस्ट के लिए देना है, एंड देन ही शुड आइडेंटिफाई कि दिस इज अ चॉकलेट. This takes about 6 to 8 years of age to identify. But if they ask you how to test it, it has to be one nostril at a time. Okay, and दूसरा nostril has to be packed. It shouldn't be an irritant, because the moment you give an irritant to smell, it doesn't stimulate the olfactory nerve. It stimulates the trigeminal nerve. So therefore, you're not checking the first nerve, you're checking the fifth nerve. Therefore, you can't give an irritant. So that's about the first. Second nerve के components क्या है? Second nerve के component है visual acuity. And can you see that the visual acuity is fine? Is actually concentrating on little things here and there. So visual acuity. Second is field of vision. Third thing, how do you know the field of vision? If I call out from here or give a red toy from here, if he is actually turning his head and actually looking at the toy, it means थोड़ा restricted field of vision है. उसके अगर आप थोड़ा सा diagonally पकड़ोगे and उधर से ही वो देख रहा है उसको, तो field of vision is okay. So this is an अंदाजे से हम लोग कैसे कर सकते हैं. Then third thing that you check in out, second nerve is fundus, which as postgraduates you're supposed to check for everyone. Okay. Why is that fundus important? It's important for, first of all, cherry red spot, etc. And it is important for papillary. And in this patient, I would definitely be interested in the papillary. Okay, so fundus, and fourth is color vision. Okay, and eye movements is not a sign of the second nerve. Eye movements is a sign of 3, 4 and 6. This is a common mistakes which all my students make. So in the exam over the years, we come to know कि क्या क्या गलतियाँ होती है आपसे. तो मैं वो उसको highlight कर रही हूँ. Okay? 3, 4, 6 कैसे check करोगे? Obvious squinting and eye movements in all the 4 quadrants. Ideally one eye at a time. अगर नहीं कर पा रहा है तो सर करके या टॉय दिखा के रेड कलर का टॉय विदाउट अ साउंड. एंड जब आप ऑडिटरी नर्व चेक करोगे या आपकी वेस्टिबुलर कॉक्लियर चेक करोगे, तब इट हैज टू बी अ बेल और रिंग और व्हाटएवर झुनझुना, यू नो, विदाउट अ ब्राइट कलर. Because if you give it with a bright color, it's going to move because of the color. Okay. So these are two things which you should carry in your exam. हम लोग मराठी में खुरखुरा बोलते हैं ना उसको, the bell. And second thing is a bright toy. You should always carry. Kids are very fond of the color red. That is a most common color because it fits their visual zones, and therefore basically their lens is tuned to that wavelength, and therefore they're very fond of red color, and therefore preferably get red toys in your exam. So you can actually see if you get a CNS test. Okay, so that's all as far as 3, 4, 6 is concerned. What about the fifth? The fifth ऐसे करो, then he knows. The moment you touch it, he doesn't like it. So that is, there is sensation. Okay, so you know that there is sensation on the maxillary, the mandibular, and the frontal region. Okay. What is the tip of the nose? Which nerve supplies the tip of the nose? So why is it important? Because it's an important part of Hansen's disease. They generally have a prolapse or that's the reason. Loss of sensation. So will you find that out for me? Yes. Yeah. First part of the trigeminal. That is the anatomical significance. You have to divide it. Correct. Very good. So that's about your trigeminal. Okay. Then 3, 4, 6, 7 was 8. I told you how to check. Ideally, in adults, you're supposed to use this tuning fork of what frequency? 512. Yes. And for your joint and vibration sense, you can use 256. So you should know the difference basically. And you know ABC, Weber, and Renes and all of that. Okay, so I'm not going to go into that because you've done that in ENT pretty well. All right. Then last but not the least is your 9, 10, 10 thing. You're basically gag reflex. So if you don't see any nasal regurgitation, you don't see a lot of thaska coming. You don't see, you know, liquid swallow karte nasal regurg coming, or a change in voice, a hemeshreshamya coming out. You know, that is how they speak. That is a typical sound of a nasal crying. And on crying, that sound is a facial, is your 9, 11, 9, 10 का sound. So that's about your 9, 10. काय झालं? तू रागवलाय का माझ्यावर? कितना गंदा लुक दे रहा है. She is तू त्याला शर्ट घालून ठेवला ना, तिला छान फ्रॉक मिळतो, उद्या तुझ्यासाठी फ्रॉक घेऊन येणार आहे. तिला काय तू असं शर्टात ठेवलंय, मला सारखा बघा वाटतो ना मग तो. Okay.
Head
So
is big.
the head is big because she is blessed with good intelligence.
Yes,
No?
genius.
So-
Shirt is fast.
So now about cranial nerves. Have you all understood cranial nerves? Have you will check cranial nerves in a small child? You need not. Have I touched the baby? No. It's only on observation. See, most of the pediatric neurological things are done only on observation. You don't really have to touch the baby and destroy the peace and calm and the comfort of the baby. Okay. So that's about the cranial nerves. Let's go to the motor system. And in the motor system, we are going to look at two things. First, we are going to look at the nutrition. Okay. We're going to look at the wasting. Now, just try to analyze whether it is a neurological wasting or it is a wasting associated with actually nutrition of the child. So, is it SAM wasting? If it is SAM wasting, it has to be gender wasting. If it is neurological, it has to be the part of it. Okay. Then, all. Then you have to look at the nutrition. You have to count the mid-arm circumference and the girths everywhere in all the four extremities. Okay. Then second part is you look at the tone. Okay. And how you see tone? You see tone by inspection, palpation, and active and passive movements. Okay. So on inspection, you see that she is dancing away to glory. So there is obviously no hypotonia. But can you see this in this lower limbs?
Right side is slightly affected then.
Ballet dancer झाली एकदम. Okay. So when you see, if your hand is like this, you know, like this, and if you see that she is actually flexing it, there is no hypotonia. So there is no hypotonia in the upper limbs, and there is no hypotonia in the lower limbs. You say lower limbs, there is no hypotonia in the lower limbs also. Okay. If there was hypotonia, she wouldn't be standing like this. She would be standing like this. So if you are lying down, is open up and माझ्या. तो चष्मा घालायचा का ठेवतो? घालायचा का? Another way of knowing hypotonia. तुझ्या मांडीत डोकं ठेव. हे बघ. नाही. सुई नाही. हे बघ. बोल बरं. बोल. Can you see these legs?
Yes.
There is no way that their legs are going. If it was hypotonia, the legs would be like this and like frogs, you know, a fitted frog. So it would be extension, abduction, and absolutely loose. So this is on inspection, okay? On palpation, feel the flabbiness of the muscle. It does feel a little bit flabby right now, but I think it's because of the SAM status rather than anything else. It's not because of neurological hypotonia. Okay, so you feel the muscle. Okay, right. So you feel the muscle. The tone on inspection and palpation is not very contributory. But what you do is that active and passive movements. On the active movements, the moment you lift, lift the baby and see, look at the legs. Can you see the left leg is going into a downward position and is coming close? That is scissoring. Okay? Can you see what is happening here? थोड़ा सा nasolabial fold उठा हुआ है, so mild facial है उसको. Okay, so the left leg is going into scissoring. If both the legs go into scissoring, ऐसे, you know there is bilateral lower limb hypertonia. Okay, so this is definitely not hypotonia. You seem to be hypertonic. Okay, then for the mandip. Then what you do is that you start looking for the passive movements. Okay, you saw the active movements. So in the passive movements, apparently which side is normal? Which side was she not moving?
Right side.
Okay, great. So if she was not moving the right side, you should start the examination on the left side. Okay. So Look at this. If it's the biceps, you feel the muscle when in extension because the calm of biceps is flexion. So tone is the feel of the muscle when it is not working. So when there is extension happening, the biceps are not working. So when will you feel the biceps? When there is extension happening. And when will you feel the tone of the triceps? When there is flexion happening. Okay. So you see that there is absolutely normal. Okay. Now, can you see this? Yeah. Ah, classical. Beautiful. Can you see? पहले खोलते हुए difficult, easy, फिर easy. Huh? This is class live spasticity. Okay. See, all of you, can you see? Okay. Can you see? ऐसे feel हो रहा है. And ये side देखो. ये how? कौन पढ़ लो? Hey, that's okay. Are you feeling giddy? Then sit down, Mitchell. Yeah, I always make one girl fall down. Yeah. Water. Funny?
I'll give you one.
Absolutely. Go. You want to lie down here? You want to sit here, bachche? You don't have to say sorry. Pani to pee. I mean, next time the glucose water do it. You all don't have dinner होगा. Dinner बिना खाए मैं आए हो क्या? अब मेरे को कल मेमो मिलेगा. Okay. Did you feel that? Very classical. Okay. So see how actually all of you must be able to see ना कि difficult हो रहा है. And ये देखो. Okay. Similarly, sorry, I should have started on the. See, look at this. Okay. And here. See. It's as if a catch is being released and again being caught. It's typically class line. If you look at the limb also, can you see this limb which is going into? Look at this limb. And look at this limb. Okay. Character. See, actually she's got a little bit of right-sided facial, I feel.
Yes.
Sure, no, इकडे बघ.
Sorry.
Can you see? There's a lot of nasal fold here. And this is, hello. Hello, can you see that? यहाँ पे fold prominent है और ये angle उठा हुआ है और ये वही का वही है. इसको mild facial है. किसने मिस किया?
मैम इनिशियली इसको था थोड़ा सा
इसको नहीं initially नहीं अभी भी है बच्चे.
फिर देन इट हैड मतलब
No, it is not yet
पहले
gone,
बिल्कुल
बच्चे.
भी
It is still there. I was just telling you ना अभी तो.
Yes.
Advika, see, you all can actually see. नहीं उसको बहुत हंसा मत. Initially I tell you when you give a बहुत हंसना then emotional component comes into the picture. And अभी देखो ना थोड़ा बहुत हंसने पे equalize हो जा रहा है. थोड़ा सा हंसी तो it's very very common. It's actually very very obvious. She's got a facial there. All right. So then you have your. If you look at her and if you make her walk, are you gonna walk with me? Are you gonna walk with me? चालू करो. चालू करो.
बुर जायचे बुर तिकडे बघ.
ए चल इकडे ये. ती स्वतः चालते बेटा. Are you gonna
राग
walk?
लगेच येतात म्हणजे हात
Can you see how she is walking? Circumduction gait. Can you see? See how she is walking. This is classical. You are a child. You are a book picture, yeah. Book picture. Oh. See how she is walking now. See. Oh, look at her leg. ना वो उठ के ऐसे घूम के जा रहा है. This was something which I told you last time. Congenital CPs में, hemiplegic CP में, you will drag the foot. Then acquired hemiplegia, you will circumduct. Didn't I tell you this last
Yes,
time
ma'am.
when I took a case of CT for you all? So this is classically a circumduction gait which has come here. Okay? So fine. And of course the gait comes at the end, but I thought I'll show it to you right now. So you've got hypertonia, spasticity, and you have to measure spasticity across all the joints. So it is across the elbow,
Elbow joint.
wrist, which I can feel, knee, and ankle. Okay. See, even in the ankle, there's a lot of it. In fact, she has a glonus. glonus था क्या माइंड उसको पहले?
initial
Pehle she had a glonus. Okay. And now we will look at the reflexes. Okay. So you will look at the reflexes. Okay. तुला नाही आलं ते बोर्ड. You have to see flying reflexes. See, फट 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 हाथ उठता है उसका. And झालं ते कंटाळा आला तिला. Ideally, you are supposed to do superficial and then deep. So superficial में बाकी का तो आप देख लोगे, but this is how just अभी ऑलरेडी Babinski's आ रहा है. मैंने ओपन हाइम किया तो Babinski's आ गया. ओपन हाइम मतलब क्या? I rubbed against the shin of the tibia. Can you see that Babinski's? This is open haim. This is shadow. This is toes. This is so this is all Babinski's extensor Babinski, which is classically seen in hemiplegia. So she is sorry. Clash केला गुड्डुली झाली. So pedicure केला गुड्डुली. And look at the Babinski's here. So it's a downward movement. Okay. So I think I've covered CNS right now. All of you go back. I will send her and we'll do the discussion. Okay.